question one. This participant currently indicates that at their practice site, they currently have a licensed social worker and a licensed professional counselor. With those two persons in place, can they begin their tele-psychiatry services or telecounseling services?
So, right. So, sight unseen, the first thing you need to do is you need to look to two regulatory sources. The first is your state legislature and see very clearly what are the requirements around delivering behavioral health services through a certified person. And it should not matter whether it's a doctor or not doctor, whether this is an allowable service. Once you've determined that that in fact is the case, the second thing you need to look to is to make sure that you have a viable reimbursement model. I can tell you that broadly, we've tipped over maybe the halfway mark across all of the 50 states that have meaningful, reasonable, helpful rules around reimbursement, but a lot of states just simply don't have a lot of guidance around that stuff. So if you can find specific language that permits it as that's optimal. Second best is simply no language at all, which sort of creates a possibility that you're going to get variable outcomes when it comes to reimbursement. And then on top of that, knowing what your state does from a reimbursement standpoint, meaning especially for behavioral health, you're going to probably find it's going to be more likely to find carve-outs or exceptions for behavioral health, in large part because we as practitioners of the mind and psyche are able to establish that therapeutic relationship without an in-person physical exam. So if you had very specific questions around what your statutes say, you're welcome to email them to me. But the short answer is absolutely. If you can get paid conventionally, probably half of our states say that there's a good chance that you'll get paid from a telehealth standpoint. But there may still be some legacy rules around that. For example, non-metropolitan statistical areas, health provider shortage areas. That continues to be a driving force when it comes to public payers. Private payers are rapidly dropping those designations because they're coming around to this notion that telehealth care is healthcare. And if they're going to offer a covered service...
Thank you. That was a very comprehensive answer. So our next question, Dr. Kim, are you familiar with any research which points to telepsychiatry being efficacious among African American populations suffering with, I guess, any mental health condition?
So I often get questioned around the questions around efficacy or equivalency. These are good questions. They are difficult questions to answer as a scientist. And ultimately, and this is again, let me caveat by saying this is my personal opinion, they are less helpful because there is a little bit of comparing apples and oranges here. If you're comparing a telehealth service for a particular at-risk population, in this case, let's say African-American men struggling with PTSD, the alternative is not conventional services with African-American with PTSD because chances are they have no option in a conventional sense. And so whatever differences you might be able to do by using elegant science to compare those two things, practically speaking, I would actually take issue with the form of your question. If you have people that are able to access a particular service, conventional or not, and you wish to figure out efficacy in that stuff, I think that's God's work. That is the reason that I was most disappointed when I formally left academia, because that was one of my favorite things to do, to ask big questions. But from a programmatic standpoint, when folks are asking me, well, why should I build this if I don't know it's going to be equivalent? My question would be, if what they're getting now is nothing, how can we not do something in order to address these things? And in doing so, so long as you adhere to the broad guidance, at least in the state of Texas, which is to say, I'm not advocating for you to just start throwing smartphones at everybody and trying to connect people up in these really cool ways. This requires that they have an established therapeutic relationship, that relationship is not necessarily predicated on only telehealth, meaning I always give the patients in my private practice an opportunity to come see me in person, if that's even possible, if they choose to sometimes. But I'll be honest with you, in my experience, the magnetic draw of being able to see your psychiatrist, in my case, without having to take a half a day off at work, being able to do it over your lunch hour from a parking garage in your car, which I've done with some people, is remarkable. Being able to find an hour or 30 minutes here or there, rather than saying, oh, I only have clinic on Tuesdays and Fridays, is a remarkable improvement on what many of my patients have come to expect from a conventional care setting. And so the short answer would be, I don't necessarily compare conventional with tele straight up. I think that there's a better comparison to be made, and what it does is it highlights the fact that we have massive needs, conventionally speaking.
Thank you. Our next question. When delivering when delivering behavioral health services or telepsychiatry, would you recommend that the first appointment or the first visit be face-to-face, or is it acceptable to have the first visit be via a telemedicine or telehealth platform?
So speaking sort of professionally from a workflow standpoint, I'm a big believer in giving people agency and free will to do things however they wish. If you're speaking in terms of how do we go about drafting common sense sort of legislation or regulations or rules around how we deliver a service, it's really, really important you note that an in-person encounter is not required, either from a clinical standpoint or a functional standpoint or anything. I have been caring for underserved, at-risk, vulnerable populations, never having met them in person. Would I like to? Sure. But if it meant I'd have to drive 3 hours to Fort Hood in order to see my PTSD military folks, or take a 2-hour flight to Covington to see my prison kids, you can sort of see. So my sense is that a lot of folks who have not yet cultivated that skill, who have not yet mastered that skill of telehealth, may have certain apprehensions and wariness. And that's where I think that good training, both in a formal setting like these webinars and an informal setting, finding people who are doing this out in the field and trying to figure this out together, is where we need to get to a better place. So once again, short answer, you absolutely do not need to see somebody in person in order to be able to care for them. But I never say never. If that's part of the process that you would like to offer, that's certainly acceptable, unless you're trying to legislate.
Thank you. Our next question.
I'd say that
first, so it's a two-part question. First is, what would you define to be the barriers to implement telehealth services in rural populations, and how?
So that's probably what I spend 80% of my brain power most days in trying to figure it out. And I would say that the biggest challenge I have is figuring out whether an access to care challenge is independent or dependent of telehealth. And I don't know all of the answers to that question. So what I mean by that is, sometimes I will offer telehealth in a certain situation, in a certain high need population, and I'll get back crickets. I will have engaged with the patient, explain the process, and they will go somewhere else. I don't know whether that stalled or failed encounter was a function of the way that we used the technology, because I've certainly seen that same phenomenon happen for pre-contemplative people coming into a conventional clinic setting who never return. So the answer becomes, if telehealth is helpful to me for anything, it is giving me an adaptable, flexible power to be able to remove excuses from my patient populations. And what I mean by that is, with respect to my private practice patients, which are one-on-one engagements, purely telehealth on a mobile platform. I have a whole spiel that I go into it, and sometimes people go for one session, or maybe they'll just text me a whole big bunch, and we'll have it back and forth, and I'll explain everything, and they will ghost me, I think is what the kids say today. But I'm able to come back and say, you know what, I have a free hour here or a free hour there, and be able to offer them with relative ease without having to turn my whole work life around, which gives them an unprecedented level of responsiveness. Now, that's how I've chosen to invest the efficiency of telehealth, meaning if I had driven out to a clinical site, A, and somebody at site B finally decides to pull the trigger on a particular day to sort of see something, I'm sort of stuck. And so there are probably people way smarter than me that are again able to puzzle out the independence or dependence of access to care challenges with respect to telehealth. The best that I can offer you is in creating or in improving or in partnering with a telehealth service solution that your organization might be doing. Those are some of the questions that I ask when trying to figure out whether this would be helpful for your population.
Okay, wonderful. Our next question.
So,
what do you perceive to be the limitations with regard to providing care, telehealth care, to a
So I've cared for both of those populations, both conventionally and from a telehealth standpoint. And speaking just purely on a personal standpoint, what I like about telehealth and taking care of this difficult population is they're almost exclusively super complicated. They require lots of attention. From a coding standpoint, it's more likely that that interactive complexity may come into play, or at least that's been my experience when it comes to sicker and more at-risk populations. What I love about telehealth is I'm able to have incredibly taxing days and have zero downtime where I'm able to go and engage with my son and my family and have dinner and do all these other things. Again, my wife, who has to drive, she's a surgeon, she drives here and she drives there, and sometimes she'll come home, she's like, traffic was a mess, and that sort of colors dinner. It's a very personal answer to your question, because when I think about challenging populations, I almost always begin with the negative impacts on physician and provider burnout, because again, as we get fewer and fewer people ready to throw their shoulder into it, as the numbers go down, we're going to start having some serious difficulties. Excuse me. A more professional answer has to do with comparing the Medicare and the Medicaid population, which, if your state is anything like my state, there is an immense differential between reimbursement at Medicare and reimbursement at Medicaid, independent of whether your state actually likes Medicaid and is investing in it. Mine does not, unfortunately, although I think that we're probably set to change given our need. But the idea that I've been approached by a number of organizations seeking to really sort of figure out how to fix Medicaid without actually expanding it, I always come back with the same cheeky answer, which is, if Medicaid would pay me the same as Medicare, which already pays me 70 cents on the dollar rather than 40 cents on the dollar, doctors are not foolish. That financial model, a sustainable, viable financial model, will work. It's just not a politically viable model. Excuse me.
Absolutely. Thank you, Dr. Kim.
I hope that answer was helpful.
Okay. Yes. Are you ready for the next one? Okay. So Allison would like to know, in your opinion, is burnout via telemedicine different than burnout associated with traditional versus burnout in a traditional clinical setting?
Wow. That is a fascinating question, because it presumes that even if a provider chose to pursue telehealth, that they would still get burned out. And I'll be honest with you, that is in fact possible, because there's nothing that would prevent telehealth work from being equally unsatisfying, depersonalizing, emotionally exhausting, all of the other metrics that we track on burnout. But it's so new that the phenomenon that I usually see are either peri-retirement or early career, or sometimes mid-career, meaning everybody, uh, making the transition to telehealth because they've burned out from their conventional job. And I have seen some people who have had a difficult time in cultivating the mastery, the skill, because it is very different. Being able to engage and establish rapport and maintain engagement across time using essentially texts and a video screen is not something that comes naturally to everybody. And so I would say that there's probably very little difference in the outcome, meaning anything could probably burn you out. And telehealth, again, just like it's not the silver bullet for patients, I don't believe it to be the silver bullet for providers who are thinking about a career change or are thinking about, the benefits, as I mentioned to you, about having zero commute and being able to have flexibility in how you live your day. But if I'm sort of inclined to say an unkind thing about some of the telehealth services, which could potentially lead to burnout, but I'm going to do my best to be civil and say that, yes, it's possible that you could get burned out in a telehealth career, which is why I would encourage folks to try to find the job that brings them joy, brings them that professional satisfaction. And if it becomes too much and it's a conventional job, see how telehealth might be able to rebalance.
Hey, phenomenal. We have just a few more questions. Our next question comes from Pascal. And this participant would like to know, how does telehealth help reduce the stigma patients may have in accepting behavioral health services?
So I can now say with near 100% confidence that one of the truly valuable things about telehealth is its ability to avoid stigma. I mentioned to you that for some of my private practice patients, they love the fact that they can literally go to their car in their parking garage at work, have a session, and then go back to work. It's enormously powerful, and it avoids a lot of the typical sort of complaints that you would hear patients say around stigma, meaning, I don't want to go to an office and possibly run into my son's baseball coach or third grade teacher or bowling partner, walking into a therapist's office or what have you. Having taken care of pretty much every vulnerable population you can think of, I have actually found a relatively low incidence of people concerned about that stuff. It's not to say that it doesn't exist in a variety of other ways, but I've sort of adopted it in a different way, which is to say, to talk about mental health care as just, again, as somebody who's trained as both an internist and a psychiatrist, I typically say, I don't know how you take care of one without the other. And with time and with continued effort in science, we learn more and more about how to take care of this as well as this. But we're not magicians and we're not miracle workers. Really, the best that we can do is to walk along the path with folks on as they figure out what being well means to them. And as behavioral health specialists, we're uniquely trained to be there in the times that cause most of our other peers to run for the doors. I'm going to give a talk to a bunch of primary care docs next week, talking about STAR-D and how do you do primary care psychiatry. And one of the pre-submitted questions was, what happens if they say they're suicidal? Well, there's lots you can do. And so the more that we can take away the stigma of mental health by just simply caring for it in better and better ways, by making a positive impact in communities, whether it's conventionally or via telehealth. I don't think there's anything unique about technology that helps me do that. Absent it, I probably would behave in very similar ways.
Thank you. Our next question comes from Melvin. Melvin would like to know if you are familiar with any patient education resources which can be used particularly for patients who may be of a lower readability level, in order to inform them about the benefits of telemedicine services and or initiating the process to initiate telemedicine, or even to communicate with a provider around receiving telemedicine services?
It's a really, really great question. And Obviously, literacy as an access to care challenge impacts us all. And this is an area where we might accidentally identify some value with tele, in the sense that one of the things when folks are interested and they actually look, that's astounding to me, is that when you look at low literacy, food insecure, home insecure communities around the country, there is not a commensurate drop in access.
Actually, we've reached the top of the hour, so on behalf of Morehouse Healthcare, we thank you for attending today's webinar.